Maryland is the only state in the country that does what? That sets the rates for every hospital in the state. So what that means is every hospital has one set of prices, essentially, that it can charge. And everyone pays against that set of prices. You don't get to charge one insurer one thing and a different insurer another thing. And essentially, everyone pays those prices. Medicare pays those prices, Medicaid pays those prices, Blue Cross pays those prices, Kaiser, everyone. If you're going to get an appendectomy at Johns Hopkins or at Sinai Hospital, doesn't matter who your insurer is, they're going to pay the same price. It is overseen by an independent commission that sets the rates, called the Health Services Cost Review Commission, otherwise known as the HSCRC. It's an independent 7-member commission that's appointed by the governor and confirmed by the state senate. The decisions are appealable to courts. There are certain members that have to have certain types of affiliations. There's one from the hospital, someone from the physician community, etc. This has been around since the 1970s. So it's a pretty old system. And the Medicare waiver was granted on July 1, 1977. So why a Medicare waiver? Every other state in the country, Medicare pays the Medicare rates for hospitals. But in Maryland, Medicare pays the Maryland rates. That requires a provision of the Social Security Act. Medicaid requires everyone to pay the same rates. State law requires it. So there's federal law, state law, and Medicaid policy. Now, why would Medicare do that? And the answer is, in the 1970s, Medicare essentially made a deal with Maryland that was enshrined in the Social Security Act, which is that Medicare will pay Maryland prices, but only if Maryland's prices don't grow as fast as the rest of the country's prices grow. Other aspects of the system. One of the most important is uncompensated care. So, hospitals have uncompensated care. In some states, there are a lot of public hospitals where the uncompensated patients are kind of pushed to. Not in Maryland. There really aren't public hospitals. In Maryland, every hospital has a percentage of their care that's uncompensated. Basically, every single patient, every single bill is about 7%. There's a 7% add-on, and that covers the uncompensated care, and every hospital gets compensated for uncompensated care. Similarly, graduate medical education the costs are built into different parts. It's not quite the same pool, but it's the same concept. Capital costs also get spread around the system. So there are a number of things where every hospital is sort of on its own in the rest of the country trying to figure out how it juggles things. In Maryland, there's a system that tries to make it more equitable. And so there's considerable value to patients, certainly to the state and to hospitals, to have the stability of a rate-setting system and Medicare participate. We certainly had grown less going from 1976 to 2007. However, what happens when you limit the price of each admission? How do you make money? Volume. More admissions. If I tell you you can only make $2 on a pair of pants, you have to sell a lot of pants. Right? You can't make $20 per pair of pants. So the system was very well geared to keeping the price down, but not very well geared to keeping the volume down. And really there were two basic problems. One is that volume in hospital services is not something that everybody's really excited about. It's expensive. It often means that you're spending a lot for the heart attack and stroke, and you're not doing a lot to prevent it. So it's not really where we're trying to go with healthcare, better outcomes at lower costs, if you're really requiring hospitals to make money to do a lot of volume. And then the second big problem is that we were no longer going to be meeting the Medicare condition of participation. Okay, so This comes from testimony that was presented to the state legislature, and there's something called the waiver cushion. So remember how I said we had to grow slower than the rest of the country? Well, the distance between how much Maryland grew and how much the rest of the country grew was called the waiver cushion. And while it was up at 17%, everybody was feeling pretty happy. When it got down to 0.72% recently, everybody's feeling very, very nervous in Maryland, because if we dipped under that, we would actually have to start paying the federal government back money. So that created some unusual conditions for change. And in thinking about what we were going to do, we had an example of another innovation that had happened in Maryland, and it's called the total patient revenue. Let me basically explain it this way. It is a budget for the hospital. It's like a global budget for a hospital, for all payers, not just for Medicare, not Medicaid, all payers. So if you're the CEO of a hospital, you would sit down with the HSCRC, the rate setting agency, and they would say, okay, last year, all your patient expenditures were, $100 million. Next year, $101 million you're going to get in a budget. No matter, here, for the sake of the math, let's just say next year your budget is going to be $100. Doesn't matter how many admissions you have. You're going to get $100. If you have 20 admissions, we'll let you charge $5 for each admission. If you have 10 admissions, we'll let you charge $10 for each admission. If you have 5 admissions, we'll let you charge $20 for each admission. It is going to be $100. That's what you're going to get. Doesn't matter how many admissions. But you're going to get it. Very different from you'll only get paid if somebody's in the hospital. So total patient revenue, there are a number of hospitals that opted for global budgets. Mainly they were rural hospitals. It was confusing to try to do that right away in an urban area where people could just go across the street to another hospital. So these are rural hospitals that are isolated. I think I've gotten a map of the different hospitals. And they saw double the reduction in readmissions, double the reduction in admissions, and almost double the reduction in avoidable admissions. So they totally changed in response to a different financial incentive. And you go into Western Maryland Medical Center, and it is like an anti-gravity kind of zone for healthcare. So the first thing you notice is the hospital is totally quiet. It was 2/3 or less full when I was there. And they're all happy about it. Then we had a tour from the CEO. He took me to the ER where they have a team that meets every patient just to find out figure out what their plan is when they leave so they don't have to come back. Every time someone gets discharged to a nursing facility, they send out a nurse twice to make sure everything's going well. The CEO, who was the CEO before this transition, said it's a total culture change, that they practically have signs up on the wall that say, we hope to never see you again. So basically, we had a situation where the old way was sort of fading, and we were going to be kicked to the curb under our old waiver, and yet we had some very promising models. Let me just point out one thing. When those hospitals, like Western Maryland, did a great job reducing their admission by keeping people healthier, then because maybe they had 5 admissions at $20 per admission, the cost per admission went up, right? They had fewer admissions under a global budget, and that penalized us under the old waiver, right? Which was all based on the cost per admission. So we really needed to shift away from that. We wanted to allow for the cost per admission to go up, but the overall cost to go down. So our hypothesis was by aligning our all-payer rate setting with other critical reform efforts, we could become a model for cost control, improved health outcomes, and a better experience for patients. Here's what we decided to do. Our goal was to move essentially all of our hospital revenue across all payers out of the fee-for-service where you get paid for each admission and into alternate ways of paying like global budgets over 5 years. At the same time, rather than have a limit on the price per admission, we'd have a limit on the overall growth of hospital expenditures, which we tied to the state GSP, the state gross state product. At 3.58% is the smooth trend over the last 10 years. And within that, we felt like we would hit significant savings against the national Medicare trend of about $330 million over 5 years. But for me, I didn't have a huge background in healthcare finance before I took this job. And so, I'm trying to figure out how to explain why we're leaving fee-for-service behind, why that is such a critical part of health. And so I've been doing a lot with the Affordable Care Act, and I was brought to the Baltimore Ecumenical Council to give a talk to some of the leaders about the Affordable Care Act, and I was late. And even when I was health commissioner, I never had met with the Baltimore Ecumenical Council before. Did not know what to expect. And I walked in, and there were 15 people, all in very severe clerical attire. And they didn't look like they were happy that I was late either. I felt very awkward. I'm not usually in a room with priests and ministers looking at me very sternly. And so I was like, I just started talking, and just trying to get, and I talked about the Affordable Care Act, and finally one of them looked at me with no emotion and said, "Why is healthcare so expensive, Dr. Sharfstein?" And I said, "Well, there's obesity and there's tobacco, and, actually cardiovascular risk factors are falling and the tobacco use is declining, but healthcare costs keep going up. It really has a lot to do with how we pay for healthcare. If we pay for every admission, we're going to get a lot of admissions. If we pay for every high-tech surgery, we're going to get a lot more of them. And that's really been driving a huge amount of healthcare costs, because that's what we pay for. We don't pay for people to be healthy. We pay for people to be sick." And I'm looking at them around the table, nothing. And finally I said, "It'd be as if each of you were paid by the prayer." Then there's this excruciating silence. And my career flashes before my eyes. I'm imagining they're going to call the governor. And finally there's a guy sitting across the table from me, but I was pretty nervous at the time, and he leaned across the table, put his hand on my hand, bowed his head slightly, and said, "Let us pray." And I realized that they understood that we've got to pay for healthcare differently if we are going to be able to get different outcomes. And that's really what we're trying to do.